Okay. Hello and welcome everyone to Hepton Store Historical Society's June talk. And we're very lucky this evening to have someone who's local to talk on, really, when I think about it, and Paul will tell us, something that is of international world importance, really. And it's the development of intensive care and ventilators, etc. And Paul will explain in detail that came about with the 1952 polio epidemic in Copenhagen. And Paul is a nephrologist, have I got that right? He's a consultant doctor, medical doctor in the field of kidneys, and he'll tell you more about his background and how he got into researching and eventually writing a book entitled Breath of Life about this subject. And of course, it's a subject, I mean, regardless, but it is in pertinent to what we've been going through in the world, really, in the last couple of years. And so hopefully it's timely in that we may be coming, we hope, to the other side of the pandemic. So Paul has a fair number of slides for us. It's going to be great. He's going to talk, he thinks, for around 45 minutes, but there's no rush. And thereafter, we will take questions and discussion. What I'd say to folks is that if anything occurs to you during Paul's talk, there's a chat facility, which is the speech bubble at the bottom. And then when we get into the discussion, there is, if you click on the participants icon, there is a hand icon, and you click on that, and then you raise your hand, and it's so, we can invite people in order of them raising their hand. Okay, without further ado, welcome to Paul Warwicker, Dr. Paul Warwicker.
Paul, thank you, Mike. Thanks for inviting me. I'll give you a little bit of background how I started, my interest in this field started. When I was first appointed a consultant, I was down in Stevenage, and part of my job was not only looking after the kidney, the dialysis unit, and looking after people with kidney failure, it was also covering the intensive care unit at Stevenage. So I had a few sessions as a physician on the intensive care unit. And I was sitting there one day waiting for a patient to come in, and I was flicking through one of the journals, and I came across this story of this epidemic in '52, and it was a journal article about some of the innovations. I thought, wow, this is fantastic. This is amazing. I need to find out a bit more about this. And there must be a book written. So I went looking in the library, shows you how long ago it was, looking in the library, couldn't find any books that had been written on the subject. And I thought, well, I'll do one myself in that case. And in those days, it was very simple to fly from our local airport, Luton, over to Copenhagen. And anybody who has any friends who are Danish know that they all speak perfect English without even a trace of an accent. In fact, they probably speak better English than I do. And it was relatively easy to speak to a lot of the people who were still survivors from the epidemic, and a lot of people who were involved, and a lot of people who were affected. And so this is the story of the epidemic in '52 in Copenhagen, and the effect it's had on us all at the present time. So here's a situation that we're all far too familiar with. A worldwide viral epidemic accelerating out of control, a health service on the brink, critical lack of breathing apparatus. We've been here before. And back in '52, a massive outbreak of polio nearly subsumed the country's healthcare facility in Denmark. I say nearly subsumed it, because this is a story of how in epidemic-torn Copenhagen, one man's innovation saved a generation of children and changed medical practice forever. It was a birth of intensive care, and it was a birth of the modern ventilator. Today, it's difficult to comprehend the fear and anxiety that the word polio inspired only a few decades ago. Poliomyelitis, known to most as polio, is the name given to the paralyzing infectious disease caused by the polio virus. It normally, but not exclusively, affects children, and classically occurred in the summer months, gaining the nickname euphemistically the summer plague. Mothers would stop their children playing with friends and keep them indoors. Apples would be washed thoroughly or even shunned, and the fall of blossom from trees could precipitate panic because of the mistaken view it would pass on the infection. And yet it was an ancient disease. There is evidence that paralytic polio occurred in ancient times. This is perhaps the earliest pictorial representation of the Emperor Ruma, and you can notice his right shriveled leg, which may have been the first person ever to be shown with the effects of polio. It was first recognized as a distinct disease in the 18th century and came into prominence in the late 19th century when epidemics started to occur. By the 20th century, the epidemics were increasing in size. They were first reported in Scandinavian countries, and then in the United States, and then throughout the world. You'll recognize one of the most famous polio victims, the 32nd president of the US, Franklin Delano Roosevelt. FDR contracted polio at the age of 39 and left him paralyzed from the waist down. Now, for the purpose of the talk, I do need to stray into a little bit of medicine, just to cover a bit of the basic pathophysiology of the disease. Polio is caused by infection with the poliovirus, as I mentioned, and we now know the usual route of entry is by the mouth. It has an incubation period of about 10 to 14 days, and it's unusual in the virus has a predilection for the nervous system. Now, most people who catch it, like some of the younger people who catch COVID these days, barely know they have it and will make a full recovery, and some get relatively little in the way of symptoms. But a percentage of patients do get nastier flu-like symptoms. And often these flu-like symptoms will flare and then settle down again. Some patients get backache, neckache, and an intolerance of light. Then often there's a second wave of the same symptoms. And these are the people who are often destined to get the paralysis. It affects the body asymmetrically, sometimes only affecting one limb. But the more severely affected lose a function of more vital systems. And these are the ones that caused the problems in Copenhagen in 1952. So if it affects the nerves from the upper spine, then the muscles of respiration in the chest wall and diaphragm are paralyzed. So the person loses the ability to breathe. This is called respiratory polio. If it affects the nerves in the brain stem, known as the bulbar region, then the victim loses the ability to cough, speak, or swallow. And he or she can't avoid saliva or secretions aspirating into the lungs, and the almost certain consequence is pneumonia. This is bulbar polio. And a lot of patients who got severe polio got both respiratory and bulbar polio. They were unable to breathe, and they were unable to protect their respiratory tracts. The affected individual can't move and they can't breathe, but they don't lose the ability to feel, to see, to smell, or to hear. I can only begin to imagine how frightening it must have been to be paralyzed, be able to hear and see everything that's going on around you, but not being able to do anything about it. Although the virus was first isolated in 1908, it was almost half a century before preventative measures such as improved sanitation and vaccination were available. And in the first decade of the 20th century, there was little that could be done for bulbar respiratory polio. Parents watched helplessly as their children asphyxiated or drowned in their own secretions. But the first breakthrough was in 1928. It was made by an American medical pioneer called Philip Drinker. He was a professor in the Department of Ventilation and Illumination, of all things. And he demonstrated that patients could be kept alive with an early crude ventilator known as an iron lung. You can see him demonstrating the technique here. And here's him demonstrating the technique of the iron lung on an anesthetized cat. I don't think I could get ethical approval to do that experiment at the moment. But basically, the way that iron lung works is the patient is put in this, it's effectively a metal box with only their neck sticking out. Everything else is stuck inside this airtight metal box, and there's an airtight seal put around their neck. Then air is sucked out of the box, and in so doing creates a negative pressure which expands the lung, pulls the chest wall out, and in so doing, draws air in through the mouth and into the windpipe, into the lungs. This is what we call negative pressure ventilation. A patient in an iron lung was effectively stuck in this machine, and it takes up to about 3 months to recover from respiratory polio. So for up to 3 months, they were stuck, unable to move, just being able to look out. Often they'd put a little mirror on top of the iron lung, as you can see in that picture, so they could at least look around the room, because they couldn't turn their head to look from one side to the other. It must have been a combination of boredom and sheer terror being in one of these machines. Just washing a patient was quite an undertaking. So to wash a patient, sitting in this box day in, day out, it must have got very sweaty, very smelly. And so to wash a patient, the nurse had to undo all the screws at the side of the machine, quickly open it up, wash the patient while they were gradually sort of asphyxiating and turning blue. They'd probably have about 45, 60 seconds to wash the patient before shoving the machine closed again, setting the machine off and getting them breathing again. Had to be done fast, as you can imagine. And there were little localized versions of iron lungs created. This is what's called a cuirass ventilator. This was put over the abdomen and the chest. And when the air sucked out, it pulled out the abdominal wall and again drew small amounts of air into the lung. It wasn't very effective. Neither of these types of technique were particularly effective or had a high survival rate, but at least they offered some hope. Someone who was going to die anyway of respiratory polio, it gave them some hope. Now, in the more affluent countries, the state, celebrities and charity organizations combined to set up huge research drives, such as the March of Dimes. And they were able to pay for suites of iron lungs, waiting like sleeping warriors to run into a summer battle every time there was a little summer outbreak. And some of these were huge, but even in the more affluent countries like the United States, by the 40s, thousands of cases of polio were being reported worldwide. And whilst most didn't need ventilators, the requirement for our iron lungs far outstretched their availability, even in the US. And in the austerity of post-war Europe, including the UK and Denmark, many countries couldn't afford the huge investment that these iron lungs demanded. But our story is based in Copenhagen in the early 50s. Population 1.2 million, just over 1 million people. In the summertime, in common with most European cities, Copenhagen would brace itself for the usual outbreak of polio. Most years, maybe a few dozen unlucky souls would get respiratory polio. In bad years, maybe several dozen. But it all changed in 1952. In 1952, Copenhagen experienced a worldwide epidemic. It was the epicenter of a huge polio outbreak, the largest that had ever been seen, far exceeding the figures for the last 3 epidemics in the United States. And at the time, the population of Copenhagen, the 1 million people, were served by a single hospital for infectious diseases, Blydams Hospital. During a period of 19 weeks, between July and December, 2,700 patients were treated with polio in the hospital, of which nearly 900 had paralysis and 316 had respiratory or bulbar paralysis. Henrik Lassen, the chief physician at the hospital, wrote, "To my knowledge, nothing comparable has ever been seen in Europe. The infection rate per unit population far exceeded the figures for the epidemics in the United States, particularly this incidence of respiratory paralysis." And in the face of this unprecedented epidemic, the staff of Blydams Hospital were equipped with 1 iron lung. Ladies and gentlemen, this is the story of the epidemic in the capital of Denmark and how the events in Copenhagen would resonate throughout the world. Let me set the scene now. A little bit about Blydams Hospital. We're going back 100 years now, 1853. The then very small city of Copenhagen suffers an outbreak of cholera involving over 5,000 people. The citizens flee the city walls and camp out in tents in the open air of the countryside. Prompted by this outbreak, the Lord Mayor resolves to build a new infectious diseases hospital away from the city centre in order to manage future epidemics. And so Blydams Hospital opened a few years later, sited on the area where the people of Copenhagen used to bring their washing. The name's Blydam, arising from the bleach they used to whiten their linens. As the demands on the hospital grew, it expanded horizontally, a bit like most NHS hospitals. And new pavilions were built, usually 1 or 2 stories. And traditionally, each pavilion housed a live-in nurse, and the senior doctors and nurses were also resident in the hospital. Former chief had a fascination for trees, and it was an unusual place. They imported strange and exotic trees in the grounds of the hospital, and the archway was impressive. It was built in the style of the great hospitals of Paris, Berlin, and London. Outside the front entrance were a series of established magnolias, not a usual tree you'd see in Denmark, which in the summer used to bloom. And above the archway was a statue of Athena, guarding the children gathered around her feet. That you might argue that the architect made a very prophetic choice in that statue. And the chief of the hospital was this impressive fellow, Henrik Kai Alexander Lassen. He was born in 1900 and he rose rapidly through the medical ranks, being appointed a chief at Blydams at the relatively early age of 38. He was the country's leading authority on infectious diseases and polio in particular. Hospitals were run along the lines of with Prussian-like authority, and he had a fearsome reputation and didn't tolerate dissent. On war grounds, he half-heartedly referred to himself as the emperor. He was a cultured man, accomplished piano player, widely read, fluent in several languages, including French and English, a passionate Francophile, well-read in philosophy and literature, fan of French art. His family were reputed to have known Paul Gauguin, and he'll prove to be one of the central characters of our story. We'll go back to 1952. Now, 1952, George VI has died and the new queen gets elected. In the States, there's an election runoff between Dwight Eisenhower and Adlai Stevenson. In Finland, in Helsinki, the Olympic Games are due to start. And in Copenhagen, the summer of 52 starts just like any other, and it's no surprise to anyone when on the 24th of July, the first patient with polio was admitted through the doors of the hospital of Blydams. Now, Lassen would have greeted the arrival of this first patient with resignation, but it's not good, but no reason to panic, no big issue. But within 4 weeks, it became very clear that this outbreak was anything but normal. The numbers of patients were rising in that exponential fashion that we've unfortunately got used to in the waves of COVID. And in the first 3 weeks, it became clear that Blydams were buckling under the strain. With only the one iron lung and a handful of those queer-ass ventilators, patients were often queuing for access to ventilation. Many didn't get a chance, and in the first 3 weeks, 27 of the 31 first patients died, often within a day or two of admission. And Lassen wrote, as the situation became worse, we were soon faced with the intolerable dilemma of having to choose which patients to treat and the few respirators at hand and which not to treat. Even with iron lungs, the mortality wasn't great. It was around 90%. And in the hospital, a sense of despair and depression was beginning to take hold. In daily crisis meetings in Lassen's office, the senior staff would discuss how to manage the epidemic with little avail. Now, one of Lassen's deputies is this chap called Mogens Bjorneboe, and on one of these weekly meetings, it was he who first urged Lassen to call in outside help. He said, look, we're just not coping. We've got nothing to offer these patients. We need to get help and we need other ideas. And he told Lassen of a colleague of his, a man called Bjorn Ibsen. In April of that year, an infant boy had presented to the hospital with tetanus, a bacterial infection that causes spasm and seizures and fits. And Professor Lassen had been on holiday, and Bjorneboe, being in temporary charge, had turned to his friend and anaesthetist, Bjorn Ibsen, and using a combination of the paralyzing agent curare and manual ventilation through a tracheotomy, was actually pushing the air in rather than sucking the air in as an iron lung does. He kept the boy alive for 17 days. But unfortunately, the child did die at that stage. And Bjorneboe thought, could this novel technique be used for the polio victims? But rather than taking suggestion, Lassen took great exception to the advice. Blydams was considered to be a centre of excellence. Lassen had an international reputation in the field. He found the mere thought of taking the advice of an anaesthetist quite offensive, remaining confident that senior physicians could work out the solution to this from first principles. Because there are two things you need to understand. Now, in 52, anaesthetics was a very low status specialty. In 1950s Denmark, as in most countries, the anaesthetist was not considered to be anything more than perhaps a glorified technician, not a proper doctor in inverted commas, not someone to whom a lot of attention was paid. The surgeon decided the anaesthetic technique, the anaesthetist just administered it. There were no permanent jobs, no departments of anaesthesia, and most anaesthetists worked as freelancers. And the second thing to bear in mind was that at the time it was thought the death from polio was due to a direct effect of the virus on the brain. It wasn't thought to be due to the complications on the respiration. It was thought to be a primary effect, pathology on the brain. So Lassen completely ignored Bjorneboe's suggestion to bring in the anaesthetist, and instead brought in one of Copenhagen's finest minds, Professor Einar Lundsgaard. His reputation in the field of applied physiology was without exception, and his ability to innovate was a matter of record. But even Lundsgaard, when he faced with the extent and the rise of the epidemic, had to admit to Lassen he had nothing to suggest. He had no suggestions at all, and he left again. And meanwhile, admissions were rising again at an alarming rate. Now, Lassen's other second in command was a chap called Fritz Neukirch. Now, Neukirch was widely liked and admired by all members of the staff. He was a soft-spoken, very intelligent man. And he also started pressing Lassen to take advice and starting to back Bjorneboe. So eventually, swallowing professional pride and a growing realization of the epidemic, Lassen agreed to consider a whole range of new solutions. A meeting would be arranged and everyone, it was open house, everyone could bring their ideas along and he would listen to every single one. August the 25th would prove to be the pivotal day. The meeting would be held in Lassen, this is Lassen's office. Everyone was invited, all would be crammed in, and Ibsen would be allowed to speak. Let me tell you a little bit about Bjorn Ibsen now. Now, Bjorn Ibsen was born in 1915 and graduated in 1940 during the Second World War. During this time, he was a surgical resident in Danish hospitals. He administered his first primitive anaesthetics. I was privileged to meet Bjorn Ibsen on a number of occasions. He told me in those days there were no oxygen cylinders, no laryngoscopes, no suction, no intravenous fluids. If you had to give fluids, you had to inject it under the skin. It would be slowly absorbed. Anaesthetics could be administered by anybody, the residents, the surgeons, the nurses, and the secretaries. Using a rubber bag, inhalation agents such as ether would be administered, leading to what Ibsen would later describe as combinations of poisoning, suffocation, and shock. His famous saying was, it was very dangerous, but there was an advantage. It was that the surgeon had to be quick. He then moved from the provinces to the University Hospital of Copenhagen, where he took up a job as a post of resident in chest surgery. And it was in this high-risk surgical specialty that he learnt some important lessons on the importance of adequate ventilation in patients undergoing chest operations. And he also got a real interest in anaesthesia, and he decided to change his career from surgery to anaesthetics. But as I mentioned, there were no departments of anaesthetics in Denmark, and he had to go to America to get training. And he managed to get a post as assistant resident in anaesthetics at the Massachusetts General Hospital in Boston. The contrast in styles couldn't have been any different. In Danish hospitals, as I mentioned, there was this chief leading a rather stifling pyramidal hierarchy, but the American doctors openly discussed post-operative complications. They kept precise medical records. If they encountered a problem, a research laboratory would be set up to address it. Everyone was able to pitch in and give ideas. He absorbed the culture and he learned from it. And when he returned to Copenhagen subsequently, he decided to specialize in anesthetics for chest surgery, undertaking 1 or 2 a week on a fee-for-case basis. And he really got a feel for the importance of adequate ventilation in patients. So he turns up at this meeting on August the 25th, 1952, with this knowledge of anesthesia, but very little of knowledge of polio. This is a pivotal moment in the history of intensive care. I met with Geoffrey Spencer, who was the former chief of the first intensive care unit in London at St Thomas's, and he describes this day as a 1066 of artificial ventilation. Geoffrey Spencer featured in that film that you might have seen recently called Breathe, about the polio victim. I think Andy Serkis produced it. So it was held, as I mentioned, it was set for midday. It was held in Lassen's office, this meeting. It was sure to be explosive, and throughout the hospital, there was over the course of the morning, there was an air of anticipation, and nearly 20 doctors packed into Lassen's office, a handful of students. Bjornebo Neukirk and Paul Astrup, the hospital's biochemist, were seated, but most of the other staff, including Ibsen, were standing, sweating in their suits. The heat was intense. There was an air of truculence and tension. There was much muttering, whispered discussion, nodding and shaking of heads. And the chief sat still, as you can see him in this picture here, reading documents, ignoring everyone in the room, a French cigarette with a little puff of smoke in the little ashtray as he sat there. And then suddenly he looked up and the room fell silent. And Lassen started by setting the scene. He said the city was gripped by a terrible epidemic, and all the indicators suggested it was going to get worse. They were all used to outbreaks of polio. This was something different. This was nothing like they'd experienced before. And in fact, by the day of the 25th, Monday the 25th, the previous week had seen nearly 500 patients with polio admitted to the hospital. He stood up and pointed at the notice board behind his desk, and you can see it there in the picture, showing the rapidly rising curve of cases, and the map of Copenhagen next to that, with the little pins for every victim of polio, showing where they all lived. So there was discussion. He opened up the room to discussion. There was discussion about the logistics of bringing in new respirators from America. There was discussion about choices of antibiotics, the value of physiotherapy. He acknowledged each suggestion, but discounted them, usually on the ground that they'd already been tried or failed, or they just weren't practical. You wouldn't be able to get enough iron lungs in to treat this many patients. And during all this time, Ibsen was standing there silently, saying very little. And the meeting almost came to a close. In fact, Ibsen told me that there were only 5 minutes of the meeting left when finally Lassen turned to Bjornebo and asked him to introduce his colleague Bjorn Ibsen. And Bjorn stood up. And Lassen immediately interrupted, even before Ibsen could say anything. And he started by asking Ibsen, he thought, can you tell the ladies and gentlemen in your room a little bit about your experience in treating polio? Now, most of the assembled doctors in the room already knew, as probably did Lassen, to be honest, that Ibsen had only a textbook knowledge of treatment of polio at best, and no practical experience of a treatment whatsoever. It was a move designed to humiliate the young anaesthetist, almost certainly. But to his credit, Ibsen countered it by outlining his relevant experience in the field of heart and lung surgery, and finishing by explaining what he felt was an analogy he saw between the case of tetanus he'd treated for Bjornebo and the young children, the young patients with paralytic polio. And he then made a really startling suggestion that the polio patients were dying of suffocation brought on by inadequate ventilation and retention of sputum. He effectively said they were drowning. It wasn't the polio killing them, the virus effects, at all. Now, behind his desk, Lassen had been shaking his head in disagreement, and he furiously interrupted, countering that the classical theory of polio gave a perfectly adequate explanation. It was a virus killing the brain that killed the patients, nothing to do with their ventilation. But Ibsen stuck to his guns. No, he countered. The room fell into a shocked sense of silence. Nobody had ever questioned the chief of Blydown before. Nobody had ever said no to him before. No, he said, it's carbon dioxide poisoning. I've seen it before in the patients I ventilate for chest surgery. It's nothing to do with the virus. These patients can be saved if we can adequately ventilate them. And he got up and he proposed a new treatment. He suggested it should be possible to treat the polio victims with positive pressure ventilation. Instead of sucking the air into their lungs, he'd get a surgeon to create a tracheotomy, a little tube in their windpipe. He'd put a cuff tube in there, and then he'd blow air in using a rubber balloon, blow it into the lungs, positive pressure ventilation rather than sucking it into the lungs. The cuff tube would protect the airway, stop secretions going into it, and you could adequately ventilate the patients in a way that the iron lung doesn't. It just wasn't efficient enough. This is a picture of his system. It's called the Waters to and fro system. It was used to anesthetize patients for sort of half an hour during an operation. It had never been used for more than, apart from that patient with the tetanus, never been used for more than a few hours in an operation. The beauty of this thing is it's a very elegant system. Is that it's the same air that passes to and fro the lungs every time the bag is squeezed. It's topped up with oxygen from the cylinder, but the carbon dioxide is absorbed by the soda lime in the canister there. So it's the same air going in and out. It's very efficient and it doesn't use up a lot of oxygen. And in fact, it was the whole technique and the whole suggestion was so simple that actually it was felt to be too simple. The physicians felt that they couldn't accept a system that was so straightforward when most medical dilemmas demanded a more complicated solution. Somewhat ironically, later Ibsen would write, a simple way of thinking does not always satisfy highly intellectual doctors. I think I understand that. But Lassen was still fuming, and around the room there was a mumbling of consent. One by one, the senior physicians were intrigued by the idea. And they thought, look, we've got nothing else to offer. Why not give this young man a chance? And eventually, Lassen was obliged to grudgingly agree. He said, yes, okay, Ibsen, you can go ahead, but you have to agree to two points. The first being that you're gambling your career on this. If you ventilate this young girl, this young patient, and it goes wrong, that's it, you're finished. I don't want to see you in the city anymore. And secondly, I get to pick the patient you treat, not you. Ibsen said, right, yeah, without hesitation, he agreed. And Lassen picked what was probably the sickest patient in the hospital, a young 12-year-old girl called Vivi Ebert, was widely considered to be in the terminal phase of polio, hopeless prognosis, and everyone was in fact about to set her up for a sort of palliative care, end-of-life care. This is a word-for-word description from the clinical record. She was in a very bad condition with paralysis of all four extremities. She was gasping for breath and drowning in her own secretions. The temperature was 40 degrees. She was blue and sweating. Well, Ibsen got an ENT specialist to create the tracheotomy, and the tube was inserted into Vivi's trachea, into a windpipe. And Ibsen started ventilating this young girl's lungs. And he was expecting to gradually improve, but she didn't. To start with, she started getting worse. She was fighting. She wasn't used to having the tube in the trachea. She was fighting it. She was clearly distressed. She was sweating. She was using what little strength she had. And around the room, eyebrows were being raised, telling glances were being exchanged. A nurse was whispering under her voice that it wasn't appropriate that a young girl should be suffering in this medical experiment in this way. This was unethical. The trial appeared to be failing, and one by one, the watching physicians, embarrassed, their eyes avoiding Ibsen, made excuses and drifted away from the room, leaving only Ibsen, the nurse, and his surgical colleague, the ENT colleague, there. And Lassen himself was called away. And his parting instruction was that by the time he returned in 10 to 15 minutes, he expected Ibsen to have ceased his treatment and the wretched girl to be allowed to die in peace. Now, after he left, in the desperate last bid to save Vivi, Ibsen decided he'd administer some pentothal and actually knocked the girl out, because it's clear she was fighting the breathing with what little strength she had left in the lungs. She was fighting the respirations, and he figured if he could actually knock her out, then maybe it would make it easier to ventilate her lungs. But the surgeon was shocked. He knew that if you gave pentothal, it was effectively a death sentence. If she couldn't breathe on her own with a little respiratory effort, as soon as you stopped ventilating, the girl would die. He was shocked. The nurse was shocked, but he did it anyway. He figured they had nothing to lose for this girl. This girl was dying anyway. And slowly but steadily, he did manage to get more and more air into her lungs. He was also able to suction out secretions using a vacuum pump from her trachea to allow the air to get in and out more easily. And by the time Lassen and the physicians came back from their lunch, the blue sweating sick child pouring secretions from every orifice had been turned into a pink warm picture of health. And not only that, Vivi would be the first patient to survive the epidemic as a result of this new treatment. His demonstration of this new treatment had left few doubters. It was shocking. But when she came around from the Pentothal, she was sat up in the chair. She was smiling at everybody. So, she was clearly a completely different person. And at a stroke, Ibsen had discredited the cumbersome, expensive mechanical iron lungs with simple, cheap, available positive pressure machines. These pumps could be brought together for a few kroner, and suddenly there was a way where large numbers of people could be treated. And for the next few days, teams of anaesthetists took shifts, treating a handful of patients with this new technique, and they were all getting better. It was clearly working. But that was a contrast. The big bulking machine that cost thousands of dollars compared with this little simple device. But the numbers were going up and up and up. The number of paralytic patients going up every day. These were the number of admissions per week. Now, each patient required a team of 4 doctors to cover 24 hours, 7 days a week for up to 3 months until they recovered. And there were only 20 anaesthetists in the whole of Copenhagen. Hundreds would be needed. Clearly, this was not a tenable long-term solution from a workforce perspective. And now you might argue that this is where Lassen came into his own. If innovation wasn't his calling, organization and leadership was. Within the first 8 days, he'd arranged for 75 children to be undergoing this treatment. And this is how he did it. Firstly, he mobilized the medical students in the local medical school. Across the medical school, on loudspeakers, on posters, by word of mouth, the message went out. Students were required to volunteer. They were briefly instructed and set to work in shifts. And when they ran out of medical students, they approached dental students. I met one of the medical students, a lovely guy, Linda will remember, Fleming Balstrup, second-year medical student at the time, and he described his first meeting with Ibsen. He said that he took us all into a side room and, perched on the side of an empty bed, began to briefly explain the situation about the epidemic, about the new treatment, and we sat in awe and in fascination. It was particularly pleasing to be treated with respect by a senior doctor. And at the end of a short introduction, we were given a 2 to 3 minute demonstration of the technique of hand ventilating a paralyzed patient. And the demonstration concluded, said Fleming, with a startling instruction. Okay, so now you start. Your shift lasts for 8 hours. There was a nervous laugh and then silence as we realized Ibsen wasn't joking, and we looked at each other in shock. And so by the end of the first week, he had 250 of these medical students doing these 8-hour hand ventilation shifts. Now, I've been at cardiac arrests before where I've used those manual bags to ventilate someone who's had a cardiac arrest. And believe me, after half an hour, it feels like your hand is going to fall off. I mean, it's, if you know, trying to do that could squeeze a balloon 20 times a minute for half an hour. It's agony. Trying to do that for 8 hours must have been really, really difficult. But he had 250 of these medical students doing the trick, and the medical students got together and sorted out little rotas for themselves. He got 27 technicians to handle 250 oxygen cylinders they would require each week. He went to the authorities and shouted at them till they agreed to increase his funding so we could increase nurse numbers by 250, 360 by the end of the epidemic. And there was, I met a lot of the medical students from time, and they said there was a real blitz spirit in the hospital with everyone pulling together with a common aim. Let me spend a few minutes just at the sort of the end of my talk now describing what it was like for the students. Imagine yourself walking down the corridors of Blydam that summer. It was the middle of the night, and as you look into the side rooms and the wards as you walk past, picked out in a halo of light, you'll see these effectively they're teenagers, they're sort of, you know, year 2 medical students. manually ventilating children, probably not much younger than themselves, for 8-hour shifts. And remember, you know, in those days, there were no artificial ventilating machines. You had to, the students did the hand ventilation without any assistance. There were no fancy alarms. If you squeezed the balloon too quickly, the kid died. If you squeezed the balloon too slowly, the kid died. If after being in your lectures all day and then squeezing the balloon all night, you drifted off to sleep, the kid died. There was no doubt that this process of ventilation must have been very stressful for the students and the nurses. Many of them were working 24 hours in a day with very little sleep. Many neglected their studies. It was said that many of them failed their final exams that year because they'd all been involved in this endeavour. And there are some lovely pictures I found in a cardboard box in the hospital library from the era. There's a young child lying paralysed in a chair with a young man ventilating him. These are the students on their tea break. They had a tea break for 5 minutes every hour, and a longer break once at night for a cigarette break. And you can almost see the stress on these young men and women's face. It must have been very, very hard for them, you know, dealing with these young children. They'd never really been faced with any clinical duties. They'd only been learning about medicine from textbooks at this stage. But they became very good. They bonded with the kids. They've been very good at entertaining the children. It must have been very boring for the kids lying there for weeks and weeks, you know, initially scared out of their wits and then just bored silly. So the students read cartoons and read books and comics. An Icelandic doctor would put on plays and puppet shows and could cut little shapes out of paper to make animals. And communication was achieved using one of these little signboards. And what would happen is that the student would run their finger along the letters, and then the child would blink when you got to the letter. And in that way, the child could sort of like, almost like Morse code, tap out a message. And there was a story. There's a real story of this really cute, angelic little girl whose name was Brigitte, who's alive to this day, and she's confirmed this story. And there was a medical student there, and she was very upset, and she clearly wanted to tell the medical student something. So the medical student started tapping out the message, and gradually the message came out: "Squeeze the balloon faster, you idiot," which was rather sweet. There are tales of personal courage as well. I'll just go back a couple of things there. You can see these big oxygen cylinders. There was one of the students told me how one of these cylinders fell over in a small enclosed side room and started shooting around the room like a jet engine when the valve fell off. And the medical student was forced to grab the child in his arms and sort of dive out the door of the room. And in another case, the tracheotomy tube disconnected and there was no oxygen going through, and the student had to manually breathe into this kid's neck, knowing full well that she was inhaling polio particles during this process. The real bravery. The students knew that they could pick up polio from these kids if they hadn't had it before. They showed some incredible bravery. That's right. So by it being a summer disease, by the end of the year, with the snows, the incidence of polio started falling, to everyone's relief. There were still a lot of patients receiving the treatment, but at least new admissions were beginning to fall. And by Christmas, by about 2 or 3 months, the kids were beginning to recover their respiratory effort. They were able to come off, a lot of them were able to come off the artificial ventilation. This is a picture from the polio ward with the Christmas trees you can see there. They were being farmed out to local hospitals for physiotherapy, rehabilitation, and in some cases, surgery to build up their muscles again. And the following year, a Swedish infectious diseases expert called Carl Engström demonstrated a new concept. He invented a machine that would do the ventilation for the students. It was the first artificial ventilator. Engström is still quite a famous manufacturer of ventilators even to this day. And they were quickly rushed into Blydams Hospital so the students could resume their studies. And they were nicknamed mechanical students. And by the end of the epidemic, these are some amazing statistics. 1,500 medical and dental students had put in over 165,000 hours of work ventilating these kids. And this is the amazing thing. They reduced the mortality of respiratory polio with an iron lung, which was about 90%, down to 20%. That completely turned around the treatment of modern respiratory polio. Now, Lassen published the findings because it's been such an amazing outcome. He published the findings in a groundbreaking article in the Lancet, very famous article in the Lancet, and this was read around the world and completely changed the practice of treatment of all paralyzing respiratory diseases. And iron lungs were almost within a few years were relegated from hospital use to museums. But he pretty much took all the credit for himself. Ibsen was sort of written out of the story. He gains one reference in the introduction. The anaesthetist Bjorn Ibsen demonstrated a technique of artificial ventilation, something along those words, but Lassen takes the credit for the rest of it. And Ibsen wasn't even given co-authorship, which are, those of you who've written scientific paper will know that's a bit inappropriate, really. Lassen was quoted as saying in that paper, although we thought we knew something about the management of bulbar respiratory polio, it soon became very clear very little of what we knew at the beginning of the epidemic was really worth knowing. Indeed. And the following year, 53, 54 as well, was when the first vaccines came in. There was another story of vaccines saving the day. Jonas Salk and Albert Sabin brought in the polio vaccines, and within a few years, the incidence of polio around the world has dramatically dropped. And recently, there was even a suggestion that it might be eradicated. Unfortunately, it hasn't been completely eradicated, but the numbers are certainly considerably less than before. You might be interested to know that a new post of Director of Anaesthetics at the University Hospital was established. And Bjorn Ibsen naturally thought he should apply for it, and he applied for it, but he was passed over by a committee headed by Lassen. Meeting in the corridor afterwards, Lassen smiled and told Ibsen, "It's a general, not the foot soldier, that's credited with winning the battle." No, it's shocking that. Ibsen felt justifiably aggrieved and took up the post of senior anaesthetist at a nearby commune hospital, where, to his credit, he set up the world's first intensive care unit. So, I mean, he's still recognised as a father of intensive care. He not only pioneered the treatment of this paralytic polio, but he also set up the world's first intensive care unit, and then the States and the UK followed. In 1972, a student returning from Afghanistan brought back smallpox to Copenhagen, and again 700 people were isolated in tents in the gardens of Blydam's hospital. But shortly afterwards, the incidence of infectious diseases dropped dramatically, and the hospital was demolished. And in its place is a famous research institute called the Parnham Institute. Now, you might be interested to know what happened to Lassen and Ibsen. Well, Lassen, to his credit, and I have to say I admire the man for this, he never gave up on the patients, and there were about 20 to 40 patients left on ventilators at the end of the process that couldn't be weaned. And some of these patients have survived to this day, and one of them, a good friend of Linda and mine, who sadly recently died, was stayed on a ventilator. She was a very impressive woman, very, very impressive woman. She taught herself Russian. She got a degree in law. She used to travel. She was a big Jane Austen fan. She used to travel to England to the Jane Austen Fellowship, all with a portable ventilator in her wheelchair. And she always spoke very kindly of Lassen. He really cared for the patients. He looked after them for decades afterwards, almost until his death. He retired eventually in the early 70s to a house in France, to his beloved France, but returned to a hospital on the final pilgrimage in 74 to die of an infectious disease, which was TB. And Bjorn Ibsen, well, I think we all owe a debt of gratitude to Bjorn Ibsen, the father of modern intensive care. I had the privilege of meeting him on a number of occasions. I had dinner with him, and he was an extremely impressive man, even well into his 90s, very forthright, and had his views on how things should be done. And he was delighted that I was writing a book, because he always felt that his contribution had been overlooked. Though it hasn't in recent years. It's definitely been recognised. And this is a picture of a very young speaker with Bjorn Ibsen in his garden in Copenhagen. Now, epidemics often relentlessly expose the shortcomings in healthcare systems and therapeutic regimens. Don't we know that? Blimey. They cast doubt on the truth of accepted knowledge and effectiveness and adequacy of technologies. They're catalysts for change. We're seeing that at the moment. And in 1952 in Copenhagen, there were the right people, the right place in the right time. And to be honest, you probably needed both Lassen and Ibsen there for the thing to have worked. You needed Ibsen for his innovation and Lassen for his just pig-headedness, stubbornness, and organizational quality to actually get this huge organization running. And I've given this talk on a number of occasions, and I think I last gave it to a Rotary Club in Preston, and before that I gave it to some doctors in a hospital in the south of England. And I used to finish it with this slide, and I used to say, we forget the lessons of history at our peril. The next epidemic is just awaiting round the corner, and everyone would laugh, and I would laugh, and think, blimey, wasn't I wasn't I right? Blimey, I wish I hadn't been, but. That's basically it. That's my little run through. It's an amazing story. I can't take any credit for this. This story tells itself. I'm merely recounting what was told to me by. I met a lot of the people. I met Ibsen. I met Fritz Neukirch, who was a lovely man. I met about a dozen of the medical students. I met about a dozen of the patients who'd been treated during that time as well. And they're amazing people, and particularly the ones that are left on the ventilator after. They're incredible. I think to survive on a ventilator for 30, 40, 50 years, you must have such strength, power of character. And it was a real privilege to have met these people. And I hope you've enjoyed the talk. And I think that's about 45 minutes, Mike. I hope that's about right.
I mean, Paul, that's just a fascinating story, interesting scientifically, and emotional and dramatic, and the personal connection that you have had with the people in it. I mean, Rochelle has written, she wrote initially, Paul, I thought this, when was Ibsen's contribution finally acknowledged? And also I thought this, how has this not been made into a film?
Yeah, very
Who
good.
would you cast? I'd cast Benedict Cumberbatch, probably as Larson, actually. But anyway,
I thought what's his name? James Bond, the original James Bond.
Sean Connery. He's dead, mate.
Sean Connery would have been a good Lassen, I always thought.
Yeah.
I wasn't sure who'd be the young Ibsen. You'd need a young thrusting actor, wouldn't you? Really. But yeah, maybe you're right. Maybe you're right. Now, it's a good question, Rochelle. I was invited to speak at the 50th anniversary of the outbreak in Copenhagen, and that was the beginnings of the recognition of Ibsen, actually, because I don't want to say it was my book, because there were a number of scientific papers that were published at that time, also talking about his contribution, particularly in intensive care journals. And at that symposium in Copenhagen, all the top intensive care doctors around the world were invited to speak, and you had this sort of mad nephrologist from England giving the opening lecture about the outbreak. So I felt a little bit out of place there, but that was the start of it. And since there were a number of festschrifts, and there was a lovely obituary when Bjorn died in pretty much all the big journals, New England Journal, the Lancet, the BMJ, all wrote about Ibsen and his contribution. And now it's much more widely recognised, and his contribution, and the fact that he was overlooked in those early days, and all the credit seemed to go to expecting to go to Lassen. And then that comment in the corridor, I mean, that was shocking. That Bjorn Ibsen told me that that line. That was, you know, it was a general, not the foot soldier, that wins a battle. So that was, to have the gall to actually say that to the man was pretty incredible. And I think he felt really upset to start with, though towards the end, as he got the recognition I think he deserved. He was an incredible man, you know. And in that era, I mean, you forget quite how. I mean, I remember in you know, the 70s and 80s how hierarchical hospitals were. Back in the 50s and 60s, it was, you know, you really wouldn't speak back to a senior doctor. And for someone, you know, for a sort of a junior doctor to stand up and tell the leading expert in the country that they'd got it all wrong. They didn't understand this disease that he'd made a career of. Must have taken some balls, really. Incredible man.
So, ventilators, which are so crucial now, have been crucial now, they didn't exist to help patients with their breathing until that point.
Now, I found that hard to believe. And I remember watching a film, one of Linda's favourite films, A Matter of Life and Death. I don't know if you've seen it, but a Powell and Pressburger film. We've got David Niven in, and he plays a Lancaster pilot who has a serious injury and sort of ends up in heaven. But there's a scene of him on an operating table, and you can see a balloon going up and down. But actually, the ventilator isn't breathing; he's breathing. The balloon going up and down is his breath sound. There were no mechanical machines to do that job until Engström invented them in '53. And in fact, the other company that started making was Bang & Olufsen. And they've moved on to making audios, haven't they? Wi-Fi.
Oh yeah, that's right. Yeah,
showing my age again here. I had a Wi-Fi. Yeah. You know, they moved sideways as well in the case. And your earlier question about the film, the reason I raised a wry smile was that my book was optioned for a film, and it looked, last year we had a Danish producer. It looked like she was going to make it, and she was co-producer with Oliver Stone on one of his big hits, and so we were getting very excited. But unfortunately, then COVID came along, and the company went bust, and all our funding disappeared, and so it crashed and burned. Unfortunately, most of these things to get optioned don't get made into films. But we had a moment of excitement, and we spoke to a couple of sort of Danish film stars at the time as well.
Well, I wouldn't give up on it. I wouldn't give up. I mean, because the other thing about it is it keeps you, just in what you're telling us, the history, it keeps you there right to the end. And
it's an amazing story, isn't it? I mean, yeah.
So is it, I mean, and it takes place in Scandinavia, and the ventilators are made in Scandinavia. And I mean, not to put too fine a point on it, the ventilators that we use today, I mean, they may have been invented in the interval anyway, but we have possibly, do you think it's too far to say that we have something to thank Ibsen for today?
Yeah, absolutely. I mean, I'm no doubt that ventilators would have been invented eventually, and you know, the physiology would have been understood, but it wouldn't have been understood that early. I think it took an epidemic these epidemics really do accelerate change, as we're seeing at the moment. And I remember in the early COVID days when we were running out of ventilators, wondering whether we could even use a sort of a modified Ibsen technique. But of course, the problem with COVID is it's sort of 100 times more infectious than even polio was. So
really,
you know, you couldn't use a hand ventilating machine, and because of the aerosol production, the risk of people contracting COVID would have been too great. I mean, in fact, none of the medical students caught polio who were treating, and that's pretty amazing. There was another outbreak in England the following year, and I think 4 or 5 members of staff died of polio. But they were very lucky in Copenhagen. It's thought that because they'd had epidemics there in the past, there was a lot of unknown immunity particularly amongst the sort of the medical student population. But they were shunned. The students, in the same way that people with COVID have been shunned, they were. One student told me about a story when he went into a cafe with another medical student to have coffee, and everybody stood up and walked away from their table, leaving a little sort of halo of space around, because they were all scared that they would catch polio from these students.
Is that in the book?
Sorry?
Is that in your book?
It is, yeah, it is.
Why are they making this film?
But
I
mind you,
don't suppose you're interested in a stage play. It wouldn't be quite as good, really. But anyway,
yeah, I'd love to put on the stage. We wrote a lovely script by a colleague of mine, Tony Phillips, and me, and it wasn't bad actually, even if I say so myself. But these things don't come. I mean, there's some wonderful other anecdotes I could tell as well. Though I mean, from the students told me, and some of the and the patients told me as well. It's heartbreaking stuff, and of course, because even with a 20% mortality, that's 1 in 5 of these kids were dying.
oh, yeah.
At the age of 18 or 19, being faced with someone you're treating dying, a little child, some of the students still bear the scars even now. So 50 years later, when they were telling me, they some of them were sort of cracking up. They couldn't finish the sentence.
It is, isn't it? I mean,
it must have been bloody hard.
It's war and it's epidemics that often lead to medical development, in plastic,
It's a paradox, isn't it? Yeah. Archie McIndoe with his plastic surgery down in Haywards Heath. Yeah.
Right. Is anybody, sorry, I'm dominating this a bit. Questions from any of our participants at all? Mary said in a message she thinks there should be a statue to Ibsen.
There should be, shouldn't there? I think it's an incredible
I've put my hand up.
Incredible man.
Clive, is that you, Clive?
It is, yes.
Come on, fire away.
Right, okay. I mean, I don't know whether you could answer this, but I was just wondering if anybody knew why the epidemic broke out in that particular time in Copenhagen, or do epidemics just, do they just happen on a random basis? Is it just chance, or did they ever kind of establish why?
They've been papers written on that very topic, why it should suddenly have chosen Copenhagen. I think and nobody really knows the answer. There clearly was some level of immunity amongst older people, but there hadn't been any large epidemics for a number of years. I think there had been 100 patients needing the iron lung in the decade before this big outbreak. So the numbers were relatively modest up to then. So there wasn't any innate immunity in the younger generation. I think this is why most of the people who were affected were young kids. A lot of them were infants, or sort of very, very early teens. And these are the ones who hadn't developed immunity. And maybe there was this new population that were ripe to get the disease. Whereas in other countries, there'd been a sort of more of a tick over of polio, and more people were being exposed and getting this. I hate to use the term that our dreaded government used, herd immunity to polio as well.
So do people I mean, you said it mainly affecting children. Do people develop a natural immunity as they get older? They're just more likely to.
Well, I think in those days you probably got exposed to polio in the same way people got exposed to measles and things. Most people got exposed to it at one time or another in their childhood when these big epidemics came, and most of them, of course, weren't affected in the same way. You get asymptomatic COVID patients, you get asymptomatic, but you got the immunity without realizing it as well.
Right. Okay.
I should mention as well that both of Bjorn Ibsen's daughters, Crystal and Birgit, I've kept in touch with, and they're amazing people as well. They carry on the memory of their father, and I remember them saying that in their childhood they felt that they'd hardly seen their father, because for a year or two while he was dealing with this epidemic, and then when he was setting up intensive care for the first time, he was barely at home, and they felt I suppose a little bit aggrieved that they'd lost out on their father in their sort of early years. And one of them said a lovely thing to me. They said when they read my book, they said that it was like getting their father back.
Right.
They understood why, why he couldn't be there. He had a sort of this calling that he couldn't avoid, which was really sweet. That was the nicest thing. I mean, I didn't make a lot of money from my book or anything like that. I can't retire to the south of France or anything like that. But the nicer thing was the feedback from people who'd been in it, saying that they'd, that this is what it had been like at the time.
Oh, how can we get hold of your book?
Well, the problem is, Mike, you can get hold of my book, but you can't, unless you're Danish speaking, you can't read it. It's in Danish. I can't read it. I've written a book that I can't read myself. I wrote it in English. It was translated into Danish by Gildendal. I was their first English author translated into Danish. But I'm thinking of trying to see if I can get an English version done.
Yeah, you know, you should. You absolutely
off the back of
should.
the COVID thing, I think there might be
Yeah.
English in it now as well. So yeah.
Diana, you've raised your hand. Diana Monaghan, I think. Is that?
Yes. I remember as a child when the epidemic came to the Hull area, and I had lots of nightmares every time my dad went off to the Hull area for work. And there's two questions I was thinking was, you know, did any of the young children, including the daughters of Ibsen, were they affected mentally like that, having nightmares? And secondly, what sort of provision would perhaps Hull Infirmary have had for this epidemic? We're talking about the 1950s, but I would think it was probably a bit later. Probably,
I think
about,
in answer to your first question, thank you for those questions. Answer your first question, I think Bjorn Ibsen's daughters were protected a little bit. They were obviously aware of what was going on. It was on the television. They told me that the King and Queen of Denmark visited Blydams Hospital. There was a lot of television coverage and things like that, and everyone living in Copenhagen was clearly scared of polio, particularly this huge epidemic. So there was a lot of fear. And as you say yourself, I don't think people now understand, or not until last year they didn't. Obviously now they do, but until last year didn't really understand infectious diseases and epidemics were like. Now clearly people know only too well what it's like. But until last year, you know, if people really thought that infectious diseases weren't an issue anymore. And sorry, what was your second question again?
Well, in Hull, I mean, I remember, I think vaccines were available, but I was just thinking what kind of treatments would have been around in the Hull Infirmary? Would it have been this?
Would have still been a 9 lung in the early 50s. Yeah, it took a few years. The paper was published the following year in 53, and it took a year or two for it to become standard practice in other countries. So by the mid 50s, they'd be using Ibsen's technique with an Engstrom ventilator. But prior to that, it would still been a 9 lung. In fact, there were still 1 or 2 iron lungs in use in the 90s in St Thomas's. Some of the polio patients preferred iron lungs when they had minor operations, but they were used for specific indications. But pretty much all of them.
I'd certainly heard of iron lung, which made me wonder, you know, if they were in the news in Hull in the 50s.
Well, I remember the pictures, you know, the fundraising things. I remember on every street corner back in the 60s and 70s, you'd see a child with a leg in calipers raising money, you know, and you'd see there'd be sort of fundraising drives for vaccination and for treatment of this thing. They sort of died out after the 60s and 70s, I think, didn't they? I remember.
We used to have to raise money for children. Well, I'm saying we have to. Primary school, that we were given it was a thing that we did, and we also turned milk bottle tops into dogs somehow for the blind. I don't know how it happened.
Peter, wasn't it? I remember that. Yeah.
Thank you, Diana. Jill had a question she's put on chat, which is, was there a way of confining the epidemic to Copenhagen, or did it go beyond?
No, unfortunately, in the States, you saw that picture I showed you. There was attempts at keeping it localized and quarantining towns. So
right.
There were towns in the States where polio broke out, and they could be effectively isolated. Now you can do that in a sort of in the Midwest, in a small town surrounded by countryside. In a big sprawling metropolis like Copenhagen, the chances of quarantine is pretty low. Obviously, people weren't going out of their own volition, trying to stay in as much as possible, but they weren't locking down in the sense that we know it now. And part of the problem was because it had already established so quickly. I mean, the rise was scarily rapid. The exponential rise was scarily rapid. That by the time that the public consciousness was aware of it, it was already pretty much everywhere in the city.
Ah, Diana's chat note there. Whole report and had lots of links for Scandinavian countries. Okay, any more comments or questions for Paul? You do, okay, look, I'll just say a few things. If anything occurs to people, just chip in. So the Historical Society we were hoping that this will be our last Zoom talk. No, I don't think it'll be our last Zoom talk. It'll be perhaps our last by compulsion. And it could be an instrument that we will use, I think. In July and August, it's going to go a bit quiet. We're going to be showing historical societies, representatives from other historical societies in Yorkshire around the village in August with Wakefield, the West Yorkshire Archive Service, who run kind of monthly meetings. And this is the first since COVID in August, and we are the hosts. We will be planning our programme of meetings for 2022, and in October we're going to resume with Andrew Bibby, who will be talking about Hope Mill and Hope Mill Cooperative. In November there's going to be a talk from the head of Hepton School, Andrew, on the history of the school. And Diana's given me a very helpful note that the Picture House has its centenary. That's in Hepton Bridge in July. Okay, and September is Heritage Weekend, National Heritage Weekend, and all being well, we will try and do an outside event on that weekend, COVID permitting, etc. However, the BBC are making, which is good news, an adaptation, I think, of Ben Meyer's book on the coiners, and are going to be shooting in the village and maybe actually filming at that time in the church and the museum. And if that is the case, they will get priority really over us. But hopefully we would like to do something on Heritage Weekend in connection with the museum and St Thomas's Church. Okay, but details of future meetings are on our website and will go out to all our members. If you're not a member, do consider joining. £5 a year. And, you know, Paul's meeting tonight, honestly, it's the stuff of BBC4 and should be a blockbuster film, I think. I'm just getting lots of little messages from people. Really interesting talk. Thank you. Any last questions for Paul before we end? Well, I think we should give him a virtual round of applause. I thought it was terrific, and we've had this is a second sort of science-based talk we had. The last one being on civil engineering, and I just think they're terrific. And because most history society talks I go to anyway, and ones I'm involved in, tend to be about social history, which and people are interested in family history and history of the buildings and all the rest of it. But stuff like this that changes and saves people's lives, and to hear it, from someone who was almost there in a way and spoke to people who were, has been a real treat. And thank you very much, Paul. And good luck with the book. And what are they missing in terms of a film? Thanks all.
Give her the day job.
Can
Yeah.
I ask Paul if you would consider having his name put forward for the Hebden Bridge Lytton Side talks, because I think that would make an excellent talk for them. And
yeah, very happy to do that. It's of course, by all
so
means.
Perhaps Michael will either pass your contact details on to me, or if he knows anybody in the Lytton Side, if he can pass it on to them.
I'll pass it on to you, Diana.
I mean, Barbara Atack is the president at the moment, but I'm happy to pass it on to her.
I'll do it to you and Barbara. Copy you in. I've got Paul's details.
Lovely. Thank you, Paul.
Pleasure.
Brilliant. There you go. Got another gig. Okay. Thanks a lot, guys. Thanks everyone for coming. Keep in touch. Take care. Bye.